Hi, Dr. Babb. Welcome to the show. I'm really excited to chat. I have a lot of questions, and I think that this could be a bit of a doozy of an episode. So thank you for taking the time.
My pleasure.
If you can start by introducing yourself. So I found you on Instagram, and I have appreciated sort of the evolution that I've seen of, I remember at one point there was sort of pencil sketches of certain things, and now there's a, a consistent theme of you kind of coming into the scene and talking about a specific topic. So if you can introduce yourself, who you are, what you do, and how you got into Instagram.
I don't know what's going on here internet-wise.
Oh, did we lose you? Are you there?
Are you there? I'm here now. Yes.
Oh, okay. Something froze. Okay, so
Yeah.
let's start that again just in case.
Okay.
I think it probably got it, but okay, start that again. Hi, Dr. Babb. Welcome. Thank you so much for taking the time to join me on the podcast today. I found you on Instagram,
Now
and
again.
looks like you froze again.
Now
There
you're
you go.
back.
Okay. What? Okay, I feel I've closed all of the main tabs on mine. Do you have a lot of tabs open up on your side?
No, not at all. This is the only thing on mine. So,
Weird.
I've got. I don't have anything else going. My internet is at. I'm trying to reset that there. I'm secured here. I'm connected.
That's so weird. I don't know why it's hang on a second. It says here, poor internet affecting the flow. Let's see. Low data mode. Turn off everybody's live video. High quality.
I can wonder if I can turn off my actual camera. I don't know if that would help, but I guess you said that it gets recovered, or you record it like that. So.
Well, I typically put in a video onto my YouTube channel as well. But are you going to be using any props or anything?
No, not at all.
Okay, so then let's turn our video off, I guess. I like it for a conversation, but whatever. We'll turn it off and see if that helps. Let's just give it a try and see. If it's working, we'll carry on. If it's not making a difference, then we'll figure something else out.
Okay, sounds good.
Okay.
So my camera's off now, so.
Okay, low data mode for all. All right, let's see what happens.
Okay.
Hi, Dr. Babb. Welcome to the show. Thank you so much for taking the time. I would love to start with having you introduce yourself. I know I found you on Instagram, and that's where I follow you. But I'd love for you to tell the audience who you are, where you practice, and what your areas of specialty are.
Okay. Well, my name is Corey Babb. I am a physician in Tulsa, Oklahoma, in the United States. I am a gynecologist by training, but then have done extra work and certification in the areas of sexual medicine, vulvovaginal disorders, and menopause management and hormone care. So I am the owner and only physician at the Haven Center for Sexual Medicine and Vulvovaginal Disorders, which is my private practice in Tulsa.
Amazing. Well, the world of menopause is definitely exploding right now, and there are a lot of people looking for help and therapies, hormone therapy being one of them. And I was speaking to somebody else the other day saying that being a vagina coach, talking about pelvic health, there's been an evolution, and there's starting to be a little bit more freedom with regards to what we can say on social media and what we can put into ads. And I actually feel that the menopause movement has played a role in helping with that because of genitourinary syndrome of menopause. So there's vaginal health being talked about a lot in that community. And I think that it has maybe played a role in helping open up the doors of conversation for other areas.
Oh, no, I agree totally. I mean, and this is something that, we kind of in the sexual medicine community struggle with all the time is kind of the censorship you sometimes get on social media, when you're saying quote unquote bad words,
Exactly.
So it's ridiculous when you're just talking about anatomy or, sexual, intimacy or things along those lines. So.
Yeah, yeah. I have been shut down so many times because the word vagina is inappropriate.
That's right.
Yeah. So I would like to start with, you mentioned vulvovaginal disorder. So maybe
Yes.
if you could start with what are the more common conditions that you treat, and there's a couple that I want to ask a little bit more specifics about.
Sure. So, probably the most common things we see in the realm of the vulvovaginal disorders are either kind of chronic vaginal or vulvar infections, and then also the skin conditions that affect mostly the vulva, but can also affect the vagina as well. Things like lichen sclerosis or lichen simplex, things along those lines.
Yeah, so that was one that I wanted to dive into a little bit deeper was lichen sclerosis and the difference between the two that you just mentioned. So can you talk about what they are, what causes them, and then also what some of the treatment methods are?
Yeah, so there's three main lichenoid disorders of the vulva. So there's lichen simplex et chronicus, which is basically the best way to kind of think of it is an eczema type reaction to the vulvar tissue. It causes significant itching and irritation, but it does not have any type of concern about progressing to cancer or things along those lines. And I mean this in the nicest way, but it's mostly more of an irritation to the patients as opposed to something to be concerned really about. Lichen sclerosis is a condition that can affect pretty much anywhere on the body. We see it on the vulva, obviously in my realm, but I've seen it on the breast, on the arm, and it's basically an autoimmune condition. So the body's immune system is attacking, in this case, the skin. And basically what you see is an obliteration of two of the main skin layers, the dermis and the epidermis. There's not as much differentiation between the two. And so you kind of get this area of thickening. It can have kind of a glassy appearance sometimes, and it often will cause the skin to become hypopigmented or turn white or pale in appearance. Now this one is typically presents with itching as well, and this is itching that may wake you up in the middle of the night type itching, and it can lead to kind of fissures or cracks in the skin. And if it goes untreated, it can cause significant alterations in the actual anatomic structure of the vulva, and can actually progress to a type of skin cancer. The third one is lichen planus, and this can affect the vulva as well, but it also affects the vagina. It also affects the mouth as well. So you're getting kind of more mucous membrane involvement, and it can cause extensive scarring, similar to, type of kind of the skin reaction like I talked about with the lichen sclerosis, but in vaginal tissue, it can actually make the vagina stenotic so that nothing can go in there. Patients will sometimes, especially if it's really not treated, they'll be unable to insert even a Q-tip, or cotton swab into the vagina because the vagina has basically sealed shut due to the scar tissue. And this one also has a malignant potential as well if it's untreated. So that's kind of the main differentiation between those three.
So before we go into the treatment piece, just a couple of things that came up. I guess the thinking about the menopause community and vaginal atrophy, vaginal dryness, the changing of the pH as we move beyond menopause and further into our life. There are many people who potentially have lichen sclerosis but may not know it. It could potentially present similarly in some capacities, or even the lichen planus you mentioned. It could contribute similarly to atrophy and dryness and irritation. Would you say that's accurate?
Yeah, and that's actually, it's a very common thing in our clinic. We have patients that come in saying, well, I'm just having vaginal dryness and there's some itching down there. And then when we actually see them, we say, aha, actually, this looks like more one of these, lichenoid dermatoses. Mm-hmm. You're definitely right in that, in terms of menopause and actually also prior to puberty, you see a larger percentage statistically of lichen sclerosis and lichen planus to a lesser extent, but definitely lichen sclerosis than you do in a reproductive age person with ovaries. But it can all of these can affect people of any age and any gender, as well. So it's
right.
not just exclusive to that. But Yeah, the
So,
hormone effect does play a role in it.
so you can develop it at any point in your life?
Correct.
And are there triggers that could, you mentioned autoimmunity with regards to lichen sclerosis. That's one piece. Are there other things that could potentially trigger it?
I mean, obviously, the things that kind of go into the whole, and I think they all are, lichen sclerosis and lichen planus, and if you view eczema as an autoimmune type condition as well, which I do. So I mean, that's going to be the big thing. We see these conditions, in families. We see them in people that often have other autoimmune conditions as well. So there's a genetic predisposition towards them, and then, like you said, there's typically some event that triggers it, and that's such a unique thing that I can't give you a definitive for that. We've seen it with illness, we've seen it with hormonal contraceptive use, I've seen it with patients get a really bad yeast infection and then it starts. So there's a number of things, but something that triggers that autoimmune response to really start that progressive destruction of that epidermal and dermal kind of barrier there to cause the lichenification.
And what is it that can lead to skin cancer? What is it about those two types that can make it cancerous?
Sure. So basically, when you're having skin change, and let me back up. It's actually probably this is a good time to really talk about what causes cancer in general. So cells have a lifespan, and at the end of their lifespan, they go through what's called apoptosis, which is programmed cell death. And so this is going on continuously in our body. Cells are being born, quote unquote, they're dying, and if as long as things do what they're supposed to, that goes in harmony. Now, when you have cells that are rapidly turning over, the skin turns over very quickly, just in general. But if you have something that is causing a metaplasia, which is kind of a change in the cell type to where it may not, it really shouldn't go that way, but it's not problematic by itself, or a dysplasia, which is a change in the cell towards a more abnormal, problematic, or pathologic kind of state. The more you have those events, the more likely those cells are to kind of ignore that programmed cell death and then become cancerous. In the case of the vulva, especially with lichen sclerosis, we do see a high correlation with human papillomavirus, or HPV, causing those type of changes as well. So in patients that have LS who also have HPV, that's kind of maybe a predisposing agent towards the development of the squamous cell carcinoma, which is usually the type of cancer that we see.
Interesting. And just to go back to the apoptosis, and another term that I have heard is zombie cells or senescent cells. So are those the ones that are ignoring the programmed cell death?
Exactly. Yep.
Got it. Okay, so we don't want many zombies.
Exactly.
Okay. So what do we do? Do these three have similar treatments, or are they all completely different?
They have similar treatments in that the gold standard of treatment for all of them is some sort of steroid cream, typically, or an ointment, but some sort of topical steroid is the gold standard for them. Now, the lichen sclerosis and the lichen planus, we are often using ultra-potent steroids for those. The lichen simplex, you can get away with not as potent steroids with it, and it will be controlled. So that's kind of the common thread throughout them. Now, there are other things that you want to consider, in postmenopausal patients, especially if they're not on any type of hormone therapy, adding, vaginal estrogens and, possibly even an estrogen testosterone combination to the vaginal and vulvar tissue can help the tissue respond better. But that in itself is not a treatment alone for the condition. Obviously, if you can find things that are autoimmune triggers, and you know what those are, avoiding those can be really helpful as well. But that's also kind of an individualized type thing. But the gold standard is like I said, steroids. There are some kind of secondary therapies we can use, especially if the steroids aren't working or patients aren't responding well to them. But that's what we're always going to start off with.
Okay. And I'm not an expert in steroid creams, but one thing that sticks in my mind about steroids is that they can contribute to thinning of the skin. Is that correct?
Right. So, and that's something that in this case, I don't want to say it's a theoretical risk, but if you are doing the steroid application properly, that the risk for that should be minimal. And when I say properly, the amount, we typically use an ointment for lichen sclerosis specifically because it has a slower absorption time. It's you can cover more space with a smaller amount. So you really only need something, actually smaller than a pea size. A pea size would be the most amount of steroid you would need. And the goal with it, is kind of starting off with daily application of the steroid. And then once you get controlled in that, you're not having symptoms, the architecture is starting of the vulva is starting to return to normal, you can start backing off the amount of application that going from daily to every other day to a couple times a week to once a week even in some patients who are really well controlled. Right. So I have yet to see skin thinning in a patient that is applying things properly. Now, if they're slathering it in there multiple times a day and there's other stuff, then yeah, you can definitely have that. But if they're doing the way that we tell them to, then that risk should be very minimal.
Okay, and then as you mentioned, a question I did have, which you already answered, is can they use local vaginal estrogen or hormone therapy? So they can, and that could potentially help with some of the like kind of offset, even if there was some risk. Would that be accurate to say?
Yeah, I mean, and that's a really good way to think about it. One of the things we see, since you brought up, GSM or the genital urinary syndrome of menopause earlier, what we see in those low hormone states is the tissue starts to retract and withdraw and become thinner and more easy to disrupt with penetrative activity or, any type of really inactivity that may cause friction. And so adding that hormone therapy allows the tissue to kind of, for lack of a better term, plump back up again. Right. And makes it more resilient to that as well. So you're exactly correct. And then if you have a postmenopausal patient, you should be having them on, vaginal estrogens kind of regardless. And that's a whole topic in itself to talk about.
Right.
But yes, I would definitely recommend that.
Yeah. Yeah. And then, I mean, I feel like we have loads of evidence for the use of local vaginal estrogen around the start of menopause for the rest of our lives for many patients. Now, you talked about estrogen and testosterone together, and this was another question that I had with regards to testosterone specifically, because it is difficult, at least here in Canada where I am, it's difficult to find a professional who will prescribe testosterone to women. There is no Health Canada approved testosterone, so it does need to be compounded. And I've heard various conflicting recommendations with regards to where to put your testosterone cream. Some say absolutely put it on the vulva, and others say absolutely do not put it on your vulva. So you're saying that we could potentially mix the two and put it there and it would be not a problem.
Right. So remember from an anatomic standpoint, so the vestibule, which is the external, or basically the kind of reproductive tract, female reproductive tract, is divided into three parts. So you have the vagina, which is the inside part, the vestibule, which is the area right at the very entrance to the vaginal canal. Vestibule similar like you'd see in a church or in a house or things, and the vulva is the external genitalia. So from an embryologic standpoint, the vestibule is an anatomic homologue to the part of the prostatic urethra. So that tissue is the same whether you are an XX chromosome or an XY chromosome. And what that means then is that the vestibule has a high number of androgen receptors, so like testosterone. And so, when you have patients that are hormonally deficient, then especially if they have tenderness or irritation in that vestibule, you can do a lot with estrogen, don't get me wrong, or estradiol specifically. But, adding that testosterone will actually be even more beneficial to helping that tissue. Systemic testosterone, there's definitely, pros and cons to that. And once again, if there is a school of thought that, well, if you're applying it vaginally, you can have issues like with clitoral enlargement or things along those lines. That tends to be very dose dependent. And so, if you're doing so, and same here in the United States, we don't have, there's no kind of approved form of testosterone for people who identify as women, because our, Food and Drug Administration doesn't believe that those people need testosterone, which is ludicrous, because the ovaries produce 4 to 10 times more testosterone on a daily basis than they do estrogens. So you're right, you do have to get it compounded, or you can prescribe kind of a quote unquote male testosterone and then dose it for someone who has ovaries. But it's like I said, the safety with testosterone really is in the dose of it, not even so much as where you're putting it per se. So.
And dosing is, I hesitate to ask a little bit, but of course everybody's going to say, well, what dose should I use? And obviously it's very personalized, and this is not medical advice. Dr. Babb is not your doctor.
Right.
But what are the sort of standard ranges that may be appropriate for women and people who identify as female?
Yeah, so basically you're going to be looking at roughly 1/10 of a dose that you would give for men or people who identify as men. Okay. So if you have, for instance, we used to do testosterone via injections, and there is a medication called testosterone cypionate, comes in a little vial, and there is 1 milliliter in that vial of medicine, and it's 200 milligrams per that 1 milliliter. So if you had a male patient, you would give him the 1 vial, that injection, that 1 ml. If you were to have a female patient, you would give them 1/10 of that, so 0.1 ml. So that's kind of the general point you want to think of. Now, in my practice, we typically start patients at around a 5 milligram per 0.5 ml of transdermal testosterone, and then we monitor testosterone labs, and we can titrate up as we need. But that's about the smallest dose that I have seen that really can be effective in patients. And then, like I said, it can go up. Sometimes we have all the way up to giving a patient, 20 milligrams on a rare instance. But usually that 5 milligrams will start to go into effect, and they'll see a benefit from that.
Okay, so I have other questions with regards to testosterone, but I want to stay on LS for a couple of more questions.
Sure.
Can things like hyaluronic acid be helpful? So that's, a lot of people, especially as they're approaching and moving beyond menopause, find benefit in vaginal moisturizer containing hyaluronic acid. Is there any reason why somebody with LS could not use that, or could it be beneficial?
No, I mean, it can definitely be beneficial. And I mean, there's nothing wrong with using a vaginal moisturizer at all. I mean, it can definitely help with vaginal dryness. And with LS specifically, we do recommend that, if like you put, let's say, your steroid on in the morning, then you also use some sort of emollient throughout the day as well to keep the tissue moisturized. So if you have a topical hyaluronic acid, or, we'll use sometimes coconut oil or Vaseline, or there's a thing here called A&D ointment. I mean, there's pretty much, the world is your oyster there in what you want to use for that, kind of emollient moisturizer type thing. But yeah, hyaluronic acid's great.
Okay. And the other thing or treatment therapy that I have seen recently that is talking about benefits for lichen sclerosis in particular is the O shot. Can you talk about what that is, and have you seen that is effective?
Yeah, so the O shot is a trademark for basically what's called PRP, or platelet-rich plasma. It was created by a doctor named Charles Runnels, and he kind of has popularized it for sexual health. So there's the O shot, and there's now the P shot for Peyronie's disease for penises, and there's other things kind of with it. But the thought is that PRP, or the platelet-rich plasma, basically the plasma that you would be injecting into the LS lesions has lots of growth factors and what are called pluripotential cells in it. And those are cells that can basically change into whatever they want. And so the theory is that that has, will be helpful in reducing the cancer likelihood for LS and healing the tissue. And the original studies for this that were done by Runnels and out at the Center for Vulvovaginal Disorders in Washington, D.C. were promising. There have been subsequent studies, however, that have shown that actually it was not effective in reducing the cancer risk. So even if patients may have felt better, the big thing with LS is hey, we don't want you to get vulvar cancer. And so, that's why the steroids have so far still been the gold standard of treatment for it. So
O-shot was more thought of as the potential reduction in the risk of cancer, not so much in the treatment of symptoms?
They were looking at both. So
Okay.
They were looking, so they said, hey, is this going to make patients feel better? And are we going to see the microscopic repair of the tissue that would decrease the chance of cancer? And what they found is that while patients may feel better, they did not see that tissue repair like they had hoped in the subsequent studies.
Right.
And so,
okay.
So you still have that risk. So it's one of those things that, there's a lot of things that are out there that may make patients feel better with it. But, the ultimate thing is, hey, are you going to have these long-term issues? So.
And then last question with regards to this topic is vaginal DHEA. So sure. you talked about the kind of the androgen receptors and the DHEA, as I understand it, helps with the conversion of estrogen and testosterone and can be beneficial where hormones may not be indicated or chosen. So can this population use vaginal DHEA like intrarosa?
Oh, sure. And since you mentioned, intrarosa is probably, this is my own professional opinion. Like, I see the most benefits with that medication for GSM and, just any type of hormonal thing. And I use it off-label for other things as well. But, like, so, yes, 100% you can get that benefit because you're exactly correct. DHEA is a pro-hormone, so it will convert into estrogens and androgens. And so, yes, you can see that effect there, too.
Got it. Are you allowed to say what the off-label uses are?
I this is my, I am not a representative of pharmaceutical company for DHEA.
Right.
So I will use it actually a lot of times. So any type of hormonal vestibulitis, whether that is in a patient who is on oral contraceptive pills, a patient who is nursing and is having painful sex, pretty much any time I see hormonal vestibulitis, I prescribe intrarosa, or get it compounded if the patients can't afford it, because I think that the benefit there is so huge, and
right.
It doesn't have any systemic spread, that we're aware of at all. I haven't seen any with patients with it, and so like it's, I've seen it work miracles.
Right.
So, yep.
Okay. And just for listeners who don't know, vestibulitis is like inflammation essentially at the vestibule you were talking about earlier. Correct?
Yep.
Yeah. Okay, so I want to move into low sexual desire, and this sort of transitions in some ways nicely. Painful sex or anything that can contribute to pain with or without insertion, with or without a partner, is a big topic.
Sure.
I know that painful sex, especially insertive sex, can be challenging for people with the lichen conditions we just talked about. Who else could be experiencing painful sex? But then I also want to kind of go into the low sexual desire, and sometimes painful sex can contribute, but there's other reasons for low sexual desire.
Right. So to answer the first question, painful intercourse, and whether that's, you divide it into kind of superficial, pain, whether, with penetration or with even kind of, exterior, non-penetrative sexual activity, or, with deep penetration, the amount of stuff that can cause it is staggering.
Right.
We really break that down into, is it something related to an organic, meaning like an organ related issue? So something like, interstitial cystitis, or, irritable bowel syndrome, diverticulitis, things like that. Endometriosis is another condition that, the textbooks always correlate with painful sex. To things, in the muscles, so pelvic floor dysfunction, where the pelvic floor is spasmed, that can be really painful, or even if it's weakened, that can be painful too. Pudendal neuralgia, so it's something nerve related. And then, one of the conditions that we treat a lot of at my clinic is a condition called vaginismus, which is basically an uncontrolled spasming of the muscles right at the entrance to the vagina, which can make penetration, almost impossible. And that can be, obviously, if patients are trying to, grit their teeth and, bear through it or whatever, can cause, all sorts of trauma to the tissue, and also psychological trauma too. And then that leads into a whole nother set of concerns. So,
and so the term dyspareunia is often applied to pain with sex where there is some sort of touch or something being inserted, and then, as I understand it, vaginismus is almost the fear of that penetration because it potentially has been painful in the past, or they anticipate it being painful. Is that accurate?
Yeah. So dyspareunia is basically an umbrella term. So, it's going to say there's pain with some sort of, sexual penetration, and I honestly think we need to kind of revise it to even say external sexual contact, but that technically at the moment falls into the realm more of vulvodynia, which is another umbrella term.
Right.
But yeah, vaginismus is basically a, pain with or with the anticipation of penetration. And you're right, a lot of times there's a panic response that's there, and so those muscles spasm as a protective mechanism. If you come towards someone and in an aggressive stance and act like you're going to hit them, instinctively our muscles tense up. We get into kind of either a fight back type stance or a defensive posture, and that's what's going on in those muscles. It's anticipating for a number of reasons that this is going to be uncomfortable, and so those muscles spasm. So.
And what would your recommendations for therapy be for? You've mentioned a few. Obviously, there's going to be different ones. But what are some of the main therapies that you would recommend
for painful intercourse in general?
Yes.
So I think the biggest thing, and what we try and do here at Haven, is really kind of get to the root cause of what's going on. So if it is, for instance, pelvic floor issue, if it's weakened pelvic floor, definitely pelvic floor physical therapy without a doubt. If it's a hypertonic pelvic floor, so it's too spasmed, pelvic floor physical therapy, and then we also will sometimes do what's called chemodenervation, or basically using Botox to basically paralyze those pelvic floor muscles. If it's a nerve issue, then you want to try and treat the root of the nerve pain, whether that's spinal or more kind of end nerve. So, and that goes into things like pelvic floor physical therapy once again, or doing pudendal nerve blocks. If it's hormonal, treat the hormones. So, once you know what the cause is, then treating the cause can often be, therapeutic, or completely therapeutic, curative even for that pain. But if it's there for a long time, your brain creates these tracks in it due to this neuroscience term called neuroplasticity. And so it basically will always then, once those tracks are there, associate pain with sexual activity. So even if you take away the painful stimulus, then it's going to still kind of associate pain there. So you also have to look at the psychologic aspect of this as well.
Right. So if somebody maybe had been dealing with some sort of pain, had that treated, they found the root cause, that has gone away, and they still they were wondering if that was contributing to their low sexual desire, but that was addressed, so now they still have low sexual desire. How do you go about addressing that and treating? that?
Yeah. So with pain, I mean, it's rather straightforward with it, because obviously we don't want to do things as a species that hurts usually,
Right.
you know. So if you have always associated sex with pain, why would you want to engage in sex, even if
Right.
you take away the painful stimuli? So that's where I like to refer to counselors that use some of the trauma-based therapies like
Mm-hmm.
EMDR, which is eye movement reprocessing, or eye movement desensitization and reprocessing.
Mm-hmm.
Basically, a trauma therapy where you take that trauma and you process through it, so it's no longer kind of hanging over everything, if you will.
Mm-hmm.
And so I think that can be really helpful then, because not only have you addressed the physical cause of the discomfort, but now you're also helping the brain to get back to where, hey, sex can be pleasurable, or not painful at least.
Right. And then in true low sexual desire, there's two I've seen you talk about and have heard. There's two medications. One's called Addy and the other is Vyleesi.
Correct.
When did those come into play? When would those be indicated? Is it a last resort, first resort? How do you address that?
Yeah, so those came into, they were released on the market here in the U.S. In kind of the mid-teens, 2000 teens. So
Mm-hmm.
I think Addy was 2000, I want to say 17, it may have been
Mm-hmm.
earlier than that. And then Vyleesi was around 2019.
Okay.
But don't quote me on, it's around that time. They
Okay.
obviously were in development a lot sooner than that. They are both approved or indicated from the Food and Drug Administration here in the U.S. for the treatment of hypoactive sexual desire disorder, or HSDD, in premenopausal patients. Now, they can be used for postmenopausal patients, or even in people who identify as men as well, and they're still really effective. It's just that the U.S. FDA has a really odd way of doing drugs for women, and that you have to specify, is this a drug for premenopausal women or postmenopausal, and if you want to get both, you have to submit a whole nother application for the other one, which is
Wow.
silly.
Yeah.
But so they work on on the neurochemical side of low sex drive, and with hypoactive sexual desire disorder specifically, basically there's an incorrect interplay between serotonin and dopamine, which are the two main neurotransmitters involved with sex drive. So the brain is the most important organ for sexual desire, and dopamine is a sexually excitatory hormone, and serotonin is a sexually inhibitory hormone. And in a person who does not have problems with sexual desire, there's a proper interplay between the two. When you are in a situation where you may want to engage in sexual activity, that dopamine goes up, and then when you're in a place that you don't really want to do that, then you get more kind of serotonergic effects there. Well, in HSDD, basically the serotonin is always high. It's kind of like driving with a parking brake on. So it takes a lot to get going, but once you get there, you can drive with it, and so it's kind of, you got to find a way to take that parking brake off, and that's where those two medications come into play.
Testosterone is also indicated for low sex drive. Would you start with that, or would you start with these first, or potentially even both?
Yeah, so the nice thing about all of these is that they do play well together. Testosterone, obviously, from a hormonal standpoint, you do get a rise in testosterone around ovulation, and that's an evolutionary thing. Obviously, you want to have sex and reproduce when you're fertile. But from a neurochemical standpoint, it's a dopamine analog. So that's kind of how it works to increase sexual desire. So it's going to increase that dopamine as well. With testosterone, I think the thing you do have to be careful about is because you want to make sure that the cause is secondary to low testosterone.
Right.
And right now, or at least here in the U.S., if you look at I guess it's actually going to be in all North America, the North American Menopause Society, so NAMS, their guideline for the treatment of low sex drive in postmenopausal women is to start with testosterone, because if they're not on hormone therapy, we're going to see that ovarian, decrease in production of sex hormones in general, including testosterone. So by supplementing it, you can increase that sexual desire. And premenopausal patients, you definitely would want to check testosterone to see if that is a cause. And if it is, okay, great, you can use that. But more often than not, that's not really the whole thing. So
right.
If you're going to use it, the other thing you have to remember is you have to monitor it. And
right.
Some patients don't want to monitor it, and some patients don't care. But I typically, personally, start with Addy and Vyleesi because they play really nicely together, and they're used in different ways. And then if I'm still not getting success and I have a patient with, low testosterone, then I will add that. So.
Okay. So when you say play together, meaning you would put somebody on both medications, or you would try one and, excuse me, see how it works and then potentially try the other one?
No, so usually I'll start them on both, actually.
Oh, wow. Okay.
So Addy is taken every night, irrespective of sexual activity.
Okay.
And it is basically inhibiting the kind of sexually inhibitory serotonin cells in your brain, and it's kind of exciting, or what's called agonizing, the more dopamine-related serotonin cells in your brain. So it's a serotonin agonist-antagonist is its actual classification. And so what it does is it makes you more receptive to sexual activity. It's not going to make you go out and say, hey, let's get it on. It's going to make you basically say, hey, that sounds like that's fun. Let's do that. Whereas before, you may have said, no, I'm not interested at all.
Right.
So, and it takes a little bit to kick in. Most patients will will start to notice changes in about a month after taking it. And so, it takes a little while to work. The Vyleesi, on the other hand, is an on-demand medication. So you're going to use it when you want to engage in sexual activity or you anticipate wanting to. And it's basically just a pure shot of dopamine. And so it's in a little injector, kind of like an EpiPen, for people that have anaphylactic reactions to whatever. And it lasts, when it first came out, they said it was 24 or 12 hours. Now they're saying more than, likely 24 or more. I have, in full disclosure, tried both of them. And the Vyleesi, it definitely works. I mean, but the main side effect that, kind of about 30 to 40% of patients who are on it will get is headache and nausea. So you want to, and it goes away.
So you want to get it on, but then you feel sick.
Yeah. So I tell my patients, hey, if you're planning to go out in the evening, take it like in the morning. Or, give yourself enough time for it to get that side effect off, because it kicks in about 30 to 40 minutes.
Oh, wow.
I took it right before I went to bed, and, I mean, it was pretty, I was like, man, I do feel kind of nauseated here. I went to sleep. I woke up the next morning, and I was, I had no side effects at all, and I, like I said, without trying to be crass, I was like, what's touching my genitals? And it was my hands. So it was like hypersensitivity. I was like, this is crazy. Like a wind blew and I got an erection type, thing. So, and it was, it definitely works. So that the Addy, its main side effect is it makes you sleepy. So you take it right before you go to bed. And so the first night I took it, I slept better than I have in, a long time. So I've been on it for a little bit more than a month. And I mean, for me, and about 70% of people are responders to it, and I am one of the responders as well. So I'm like, hey, this is definitely kind of increasing my level of desire. And like I said, the sleepiness, I usually get between 6 and 7 hours of sleep a night, which I know I need to get more. But I don't feel groggy when I wake up in the morning with it. So
yeah, that's both, interesting.
Yeah, a success for me. So obviously that's just so, but.
Yeah, but the sleep part is interesting too, because especially in the postmenopausal population, well, even in perimenopause, sleep is often a huge challenge. So,
totally.
Interesting. Okay. So I'm not going to get a chance to get to everything, but I did want to come back to one more question about testosterone. And I think we'll have to have you back on here for a part 2 to get all the other questions that I had for you.
Oh,
but
gotcha. Okay.
With regards to testosterone, coming back, we had talked about that a little bit earlier. The part I want to ask is pellets. So I've seen lots of controversy as well on pellets. Some people say they're life-changing and it's the best. You put it in and you don't need to think about it. And other people say it's dangerous because too high of a dose and it's slow release. So interested on your thoughts on hormone pellets specific to testosterone.
So no specialty society that really deals with, women's health or hormonal health recommends the use of pellets for women or people who identify as women. And like you said, you hit the nail on the head there. The issue is you end up with these super therapeutic levels of testosterone, and that can definitely cause problems, some of which can be reversible when you come off of it, but others can be actually permanent. I've seen patients who come in and, and don't get me wrong, patients typically feel wonderful on the pellets. Especially, usually about the first month that they have them, and then they start to kind of notice that the fall in testosterone, then they start to get really irritable and achy and angry, and they don't feel good until it's time for, here's another pellet. And the big issue, though, like I said, I've seen patients whose testosterone is higher than mine with the pellets, and those patients, they'll say, why is my hair falling out? Why am I getting acne? Why is my clitoris enlarging? Or I have one patient that has, voice deepening permanently from it. When those virilization things start to happen, they're often not reversible.
Right.
And so that is why I do not recommend them. With the daily transdermal testosterone, we can get you to a steady state to where you're getting the same amount every day, and that testosterone level is really not budging much.
Right.
And so that's why I, prefer that. And that's the recommendation from both the North American Menopause Society, the Endocrine Society, and then also the International Society for the Study of Women's Sexual Health. That's kind of the preferred method.
Right. Yeah. Okay. And last question I'll ask for today anyway would be, can testosterone, if it was indicated, we've tested their levels are low, they have some other symptoms potentially, could increasing testosterone levels systemically or maybe even locally, could that, meaning local application versus systemic application, could that influence the strength, endurance, resilience, reaction time of the pelvic floor muscles? So people who have incontinence and
that's a great question. So the short answer is yes. You definitely see, and that's one of the things, we see with patients, especially menopausal patients who go on systemic testosterone. They say, I feel stronger if I have more muscle endurance. If I am exercising, I can go longer without feeling tired. I'm not fatigued in general. I have more mental acuity. So, no, 100%. It can be very beneficial for, even it just, like I said, for a local application, you'll still see some muscular improvement with it, but usually if you're doing those patients, or if you're seeing those, you'll probably put them on a systemic form of it,
Right, right. And I can attest, so I use systemic testosterone, and I can definitely attest to the more energy, more endurance. I don't get so fatigued. Right. It made a really big difference for my sort of capacity throughout the day, if you will. So yeah, I'm a user and a believer.
Okay, exactly.
Yeah, but I have a whole list of other questions. I really would love to have you back for a part 2 if you are open to that.
Of course.
I've loved this conversation. I love your approach to it, and I'm really grateful for you sharing your time with us today. So thank you so much.
No, it's my pleasure. Thank you for having me.
All right. See you again.
All right. Thanks. Bye.